Fat embolism. So we know that fat embolism, usually the clinical history, what they will be giving? They will be giving a fracture of the multiple long bones. And this is usually the common precipitating factor, especially after a road traffic accident when there is a fracture of multiple long bones. Actually, clinically, there is characterized by triad of hypoxemia, neurologic abnormalities and petechial rashes. So usually when the symptoms will be onset, so it will be not immediately, the fat embolism symptoms will not given symptoms will be immediately, but it will be like a 24 to 72 hours after the post injury. So you can see here the question related to it. A 42-year-old male with a history of motor vehicle accident was admitted with multiple fractures, including a comminuted fracture of the femur. On the third day of hospitalization, he developed a sudden onset of dyspnea. So that classically the symptoms will be like this: sudden onset of dyspnea, tachypnea and hypoxemia. So despite aggressive treatment, the patient condition deteriorated and he passed away. What is the most likely diagnosis considering the clinical and histopathological findings? Yes, so we know the clinical, and let's see, quickly revise about this histopathological finding. So in the pulmonary vessels, again you can see here the empty white spaces, that is not stained, that is these things are fat things are washed away, so they are like empty fat globules which are appearing white in the histopathological sections. So again with the classical stain with the oil red wood, these fat particles are highlighted, and so the diagnosis here is the fat embolism syndrome. So there is a clinical clue is multiple fractures, and this is a comminuted fracture of the femur, like multiple long bone fractures. The marrow material would have seeped into the torn blood vessel, so resulting in the pulmonary embolism. Moving on to VSV22, amniotic fluid embolism. The onset of amniotic fluid embolism usually like after the labor or during the process of the labor, when the patient will be complaining of a severe dyspnea and also hypotension and hypoxia. Clinically, the features can include shock, DIC, seizures, and patient can even go for coma also. So what is the classical histopathological findings and the autopsy? Pulmonary vessels, if you could demonstrate this in the pulmonary vessels, the fetal squams and the fetal has, that is the lanugo has, and the caseous vernix caseosa. So all these things points out towards that this is a case of pulmonary embolism. Actually, these materials are being shed in the amniotic fluid embolism. This material is being shed in the amniotic fluid. So with the amniotic fluid, you can demonstrate these materials in the pulmonary vessels. So let's see the clinical history, how they are framing with this. A 32-year-old woman experiences dyspnea, hypotension and seizures post-delivery, leading to cyanosis, DIC, coma and death. So especially all this started after the delivery. And post-mortem examination of the lung vessels, this is a classical image they can give you with the pulmonary vessels actually showing this vernix caseosa and the fetal squam cells. Okay, these are all the squam cells, and what's associated with the condition. So they are asking us like what can be the probable etiology of this condition. So this is not immune reaction to the fetal cells, we cannot occur post delivery and leading to under death, and cytokine storm from fetal material in the circulation. So it is not in the actually mainly due to the cytokine storm. It is not due to autoimmune attack on lungs triggered by fetal hypoxia material. It is because of the maternal coagulation, that is the DIC, activated because of the amniotic fluid in the blood. The amniotic fluid in the blood activates the maternal coagulation system. So all this results in this amniotic fluid embolism, the manifestations. Moving on to the VSV23, white infarct. The other names for white infarct are pale infarct or anemic infarct. They are usually seen in the solid organs and usually because of the arterial occlusion. So you can remember end arteries, wherever the end arteries are there, you can get this white infarct. Occlusion of these arteries can result in the white infarct. As you can see in the coagulative necrosis, we saw the solid organs, heart, kidney, spleen. Here white infarct also are commonly seen in the heart, kidney and the spleen. Yes, typical infarct are this wedge shaped infarct. Yes, typical white infarct are the typical wedge shaped infarct. So keep this in mind. So in solid organs, heart, kidney, spleen, white infarct, pale infarct, anemic infarct. And the question, let's see the question. A 67-year-old patient with untreated atrial fibrillation develops a sudden flank pain distress and irregular heartbeat and kidney injury. So patient is a case of atrial fibrillation suddenly when he is developing flank pain distress. So renal angiogram shows limited blood flow to the part of a left kidney. So this tells that the patient is having some vaso-occlusive lesion in the left kidney. So the patient undergoes the surgical exploration and representative gross image of the left kidney is shown in front of you. So what's the likely cause? Yes, as you can see here, wedge-shaped infarct, pale infarct, that is something is occluding the renal vasculature resulting in the infarct. Let's see what can be the causes. Renal vasculitis from microscopic polyangiitis, usually vasculitis cannot present with a irregular heartbeat and the kidney, like this kind of wedge-shaped infarct. Renal artery blockage from a cardiogenic embolism. Yes, this patient is having a case of atrial fibrillation. We know that actually fibrillation, there is a more prone for chance for this thrombus formation. Yes, stasis that can result in the thrombus formation, and from there cardiogenic embolism would have ensured. So let's see the other options also. Glomerular diseases caused by from lupus nephritis is unlikely in such a case of a 67-year-old patient. And malignant nephrosclerosis with a high blood pressure is also not fitting here, because the patient is not, there is no history of like something to do with a hypertension, because now the patient is having a clear-cut history of atrial fibrillation. So this is actually a cardiogenic embolism. So the cardiac cause resulting in the embolism blocking the renal artery, resulting in this wedge-shaped or pale infarct. Moving on to VSV 24. Red infarct, or otherwise called as hemorrhagic infarct. You can see here the affected organs, the affected infarcted tissue appears hemorrhagic in nature, reddish in nature. This hemorrhagic infarct is commonly seen in the organs with dual blood supply, double blood supply, like your lungs, liver, and in the intestine also. Even in the intestine also you can see this red infarct. And previously congested organs like your nutmeg liver, like CVC liver we saw, no? So the infarct we saw CVC liver, that is central area, central zone, there will be hemorrhagic necrosis. So that hemorrhagic necrosis is nothing but your red infarct. And reperfused tissue, like again if there is a reperfusion occurs, there you will be getting this red infarct. Let's see a question with this red infarct. A 42-year-old diabetic male with a pleuritic chest pain, cough pain, smoking history and obesity has a pulmonary embolism and worsening hypoxia after starting anticoagulants. What's the embolism source and nature? So whether it is a thrombosis from diabetes causing bland infarction? No, this we are ruling out, because this is not a bland infarction, because this is not appearing like a pale in color. This is look like a dark red in color. That is the hemorrhagic infarct we are thinking from this gross image. And deep vein thrombosis embolization causing hemorrhagic infarction, yes, that is a high likely possibility, because the patient is having cough pain. So he is having a long standing history of a smoking history. So in a smoker history with obesity and also with the chest pain, actually we are now thinking of that DVT, that is the deep vein thrombus, because of the cough pain, deep vein thrombus that would have gone to embolism, that would have gone for the pulmonary embolism, resulting in the hemorrhagic infarction. So DVT, pulmonary embolism, resulting in the hemorrhagic infarction. So this is the correct answer. So there is no source of infarction causing for this septic embolism, and we know that fat embolism, actually that fracture history will be there, but here nothing such history. And the cough pain and obesity, smoking, or the classical things points to our diagnosis, DVT causing this hemorrhagic infarction, embolism causing this hemorrhagic infarction.